Good morning, everybody. I'm delighted to be presenting today at ISWARS and as a part of the DIOS session. Actually, I've been presenting in the ISWARS now for 35 years. I can't believe that all these years passed. Since 1992, I've been presenting. And now I belong to the DIOS and belong to the ISWARS. I'm very happy and fortunate to do that. My topic today is about corneal melting in rheumatoid arthritis. It is a very important topic which we all face, and I just want to highlight some of the important clinical and treatment issues. First of all, rheumatoid arthritis is a systemic autoimmune disease which primarily affects joints, but it also can affect extra-articular tissues. Ocular involvement in rheumatoid arthritis include dry eye, which is the most common presentation, scleritis, peripheral ulcerative keratitis, which we usually refer to as PUC or PUK, corneal melting, and this is the most severe presentation of rheumatoid arthritis in the eye. What do we mean by corneal melting? Corneal melting, it's a progressive corneal stromal degradation which leads to thinning, ulceration, and even perforation. Sometimes thinning occurs without an epithelial defect. The pathophysiology of corneal melting in rheumatoid arthritis includes the deposition of immunocomplex in the vessels, leading to vasculitis, and this will lead to the release of proteolytic enzymes like collagenases and matrix metalloproteinases. And these cytokines will lead to stromal collagen degradation. Risk factors for corneal melting, long-standing rheumatoid arthritis. I mean, not any case of rheumatoid arthritis is exposed or at risk of corneal melting. These factors should be present. Long-standing rheumatoid arthritis, high disease activity, positive rheumatoid factor and anti-CCP, systemic vasculitis, and severe dry eye. It usually occurs in a patient with chronic severe dry eye. Usually the patient of corneal melting or keratitis in rheumatoid arthritis present with severe pain, redness, photophobia, and decreased vision. When you actually examine the patient, you will typically find a peripheral crescentic ulcer, and it may be paracentral. You may find frank perforation. The patient may present with frank perforation and iris prolapse. And the important issue is that usually there is bilateral affection, but with different levels of affection. And it could be also unilateral. But when it is bilateral, you should usually suspect an autoimmune etiology of this problem. These are two photos, with the photo on the right, on the left, presenting peripheral ulcerative keratitis, and one to the right, it is a relatively paracentral lesion with peripheral vascularization. The photo on the left presents a more aggressive form of PUK, and the photo on the right presents an ulceration with iris prolapse due to perforation. When we come to treatment, when you come to treat a patient with corneal melting from rheumatoid arthritis, you should start with intensive systemic immunosuppression in collaboration with a rheumatologist. And this is the most critical issue, that we usually find it difficult to deal or to communicate with the rheumatologist. But you have to start with immunosuppression. The most effective and rapidly acting drug to immunosuppress the patient is systemic corticosteroids. It is essential for rapid action, as I said. And also you have to use the conventional drugs like methotrexate, mycophenolate, mofetil, azathioprine, or cyclophosphamide. These drugs are usually very effective, but they usually take some time to reach the therapeutic effect. So we usually start with systemic steroids for rapid action, and these conventional immunosuppressive drugs, one of them. Myself, I usually start with methotrexate 25 milligrams, which is 1 milliliter per week. Mycophenolate mofetil, known as Celcept, 500 milligram, is very effective, but it is more expensive than methotrexate. The azathioprine is also effective, but I usually give it as an adjunctive treatment with Celcept or methotrexate. Cyclophosphamide is a relatively dangerous drug which should be given by the rheumatologist, not by us ophthalmologists. If the patient is not responding to this conventional treatment, we usually convert him to biological treatment like rituximab, infliximab, known as Remicade, or adalimumab, the Humira. These drugs are expensive, but they are usually very effective in managing rheumatoid arthritis patients. Local therapy or topical treatment is just adjunctive, it's just palliative, but it is not the treatment. We give preservative-free lubricants, topical cyclosporins, and also I just missed to write that we give topical antibiotic as a prophylactic measure. But the most important thing in this context is not to use topical steroids, which because topical steroids they activate collagenase enzyme in the corneal stroma and leads to more corneal melting. So in ulcers related to any immune system, any autoimmune disease, you should not use topical steroids. Surgical management of perforations usually deferred or postponed until adequate control of inflammation. Don't rush to do a patch graft or glue for perforations due to rheumatoid arthritis. But when we control the disease after 2 weeks, 4 weeks, you can use a cyanoacrylate glue or a bandage contact lens for small perforations, or you can use an amniotic membrane graft, or you can use a tectonic keratoplasty if the perforation is large, and after, of course, control of the immune system. The takeaway messages for managing corneal melting in rheumatoid arthritis: it is an ophthalmic emergency. You should manage the patient rapidly. Systemic immunosuppression is crucial before any surgical treatment, and you have to postpone surgical intervention until adequate control of the immune system, even in perforated cases. Don't panic. Perforation is not that the eye is lost. You can wait until proper conditions are available. Don't use topical steroids for melting or corneal ulcers due to rheumatoid arthritis or any other autoimmune disease. It is a multidisciplinary management. You have to involve a rheumatologist in your management of this a devastating disease of the cornea to reach better results. I have many patients along my career which I didn't patch, I didn't do any surgical intervention, and they are now, after years and years of their perforation, they are enjoying good vision in a previously perforated eye. Thank you, and don't forget or mark your calendar for the 4th DIOS meeting in Tunisia. I expect it to be a very rich and entertaining meeting, so we meet you there, inshallah.
Thank you very much, Dr. Alaa, and thank you for highlighting the DIOS meeting in Tunisia. يعني هو هيبقى a multitude of subspecialties in the ocular surface. وطبعا تونس بلد جميلة وقريبة منا كمان. In continuation, دكتورة نانسي حازم هتتكلم in a similar topic of the immune ulcer. لحد ما الدكتورة of the cornea under the different autoimmune conditions and devastating conditions. I beg to differ بس في مسألة الكورتيكوستيرويدز لأن the peripheral corneal ulcers is strongly sensitive للكورتيكوستيرويد and it heals immediately. ومش عارف إذا كان الدكتور أسامة يوافق على ده ولا لا. ده هي الحالة الوحيدة اللي أنا I push strong corticosteroid topical one. What you should never use is the non-steroidal anti-inflammatories طبعا. دول كلهم melting 100% in few hours. لكن corticosteroid I push a strong corticosteroid in such cases and they heal marvelously. مش عارف رأيك إيه يا دكتور أسامة؟
طبعا أنا بأيدك جدا في الموضوع ده. يعني دايما حتى في كلاسيك تيتشنج بنقول إن البريفرال أرثر
دي الحالة الوحيدة اللي بتستجيب للكورتيزون. الروماتويد arthritis. When you push with systemic, of course, and you should control it bilaterally, but I push a strong corticosteroid and they heal marvelously. دي الحالة الوحيدة. The cornea and the ocular surface is studied with the maximum number of the immune response and immune cells, and you should nullify them with the strongest اللي هو non-definitive أو يعني ما هوش specific anti-inflammatory and potent autoimmune is the corticosteroid. مش كده برضو؟
I object.
لا بس دكتور أسامة موافق. ما هو يعني ما هو
في الإيرلي أنا دكتور علاء قال ما تديش لما يكون خلاص impending perforation أو already perforated. ده اللي أنا ممكن أوقف فيه. إنما early I use مع السيستميك اميون سبريشن او لازم يكون كنترولد سيستماتيكالي. بدي معاها لازم تتراسايكلينز وادي معاها اتوبيكال ازيثرومايسين. دول ده اللي لازم، والحاجات اللي هي بتبروموت الهيلينج انتي انفلاماتوري.
طبعا لما تكون بالمنظر بتاع البرفوريشن والايرس بره ما اظنش
طبعا بالمنظر ده الامبندنج برفوريشن
البريفرال
والسراوندنج انفلتريشن معاها ما بديش استرويد. هيبقى هنا الرول بتاع الهيستو اكريل مع الامنيوتيك
عشان بس تبقى المسج واضحه للاودينس. امتى ندي الاسترويد
في الايرلي؟
نقطه مهمه جدا. بريفرال فيري ايرلي انا شخصيا بخاف، ولما بتجرأ قوي بعمل حاجه ما اعرفش اذا كان صح ولا غلط، اقول له تاخد التوبراديكس مرهم ده النهارده وبكره وتجيلي بعد بكره. ده اللي بعمله لما بكون جريء جدا، لكن عاده بخاف ان انا ادي لوكال ستيرويدز في الروماتويد.
They respond marvelously and they have its own theory.